Everyone. My name is Destiny Braden, and I am the Development and Operations Manager at the TANGO2 Research Foundation. And it is my pleasure to introduce Nikita Gogate, our last presenter of the day. Nikita is a PhD student in genetics and genomics at Baylor College of Medicine and studies rare disease genomics and genotype-phenotype relationships through integrative clinical genomic analyses. She completed a clinical translational certificate program under Dr. Seema Lulani, advancing a clear path from bench to bedside. Her work on TDD evaluates 120 individuals from the natural history study, applies phenotypic analysis to delineate subgroups, and identifies an association between the G154R variant and metabolic crisis. Welcome, Nikita.
Hi, thank you for the introduction and thank you for having me here. I'm truly inspired listening to all the talks today, and it was a great setup for what I want to talk to you all about today with the Tango 2 natural history study and the things that I have been learning from that study. Let me see if I can control this. Okay. I pressed, I think, too many keys too fast. Okay. So, as you all know, TANGO2 deficiency disorder is a rare disorder, but still is estimated to affect over 8,000 individuals worldwide. And it was first put forth in 2016 with a bunch of phenotypes, the cardiac and metabolic crisis for sure, but then the seizures, spasticity, hypothyroidism, developmental delay, and intellectual disability. So as we've talked before, you have your baseline health, and you may have TANGO2 spells, but you lack any lab abnormalities. But when you are having any stressors, you may go into metabolic crisis and even cardiac crisis. So I'm not going to go into much detail here, but try and move on. So the first natural history study was then published in 2023. There were 73 cases from 57 unrelated families, and then 65% of them had metabolic crisis, and then further had cardiac crisis. But the main takeaway that we all have is how multivitamin, especially vitamin B5, helps in preventing the metabolic crisis and cardiac crisis. So now in the expanded cohort that I studied, we have about 120 individuals. 17 of them are TANGO2 angels. There are 83 families from 22 countries. The male and female ratio still remains the same, and there's a whole spread of self-reported race and ethnicity in this cohort. And I think Dr. Sergio went through most of this, but I'm just going to reiterate. So the median age of our participants were about 12 years. They range from 0 to 42 years of age. The age at first spell, the median age was 1.5 years. And then the age range for the first spell also ranged from 4 months to 6 years. And then for the metabolic crisis, the median age was 2.9 years and had a range from 2 months to 27 years. And 64% of them at least had one metabolic crisis. And then if there was no crisis, the median age currently is about 7.1 years. So I have noted this the whole spread of TANGO2 phenotypes, and I'll talk more about phenotypes and why they're important to note these phenotypes in the natural history study. Every case, when you put in the survey question or any phenotype that is noted by the clinician or any specialty, is very, very important for the studies like what I do here. So here I'm just showing you that we do have the spread of both yes and no phenotypes and, the number of cases. So TANGO2, as you all know, is present on chromosome 22 at location Q22Q11.2. Um, it has 9 exons and then 276 amino acid long, and it plays a key role in ER to Golgi transport and mitochondrial health. And recently, we've seen that oops, it is an acyl-CoA binding protein. Okay. In our TANGO2 cohort, the natural history study, we have 4 cases that also have the 22q11.2 deletion, and the number of exonic deletions are marked here, as well as different missense and splice variants, um, and the number of cases that we see with these different variants as well. So far, I'm showing you how we have 122 individuals from 83 families across 22 countries. And then there are 3 questions that I'm asking from this cohort today. So the first question is, do different gene variants cause different features in the TDD? And to do so, I looked at all the phenotypes that I've listed before, and I took the top 3 variants that we see. So the 22q11.2 deletion, the exonic 3 to 9 deletion, and then the G154R variant, and then tested them across every phenotype that we've seen to see if there is any enrichment that I can see using Fisher's exact test and odds ratio. And so here is what you see overall. So I have all the 3 genotypes on every row, and then the p-values listed across, and then all the phenotypes on the x-axis. And you can clearly see that with the G154R variant specifically, you have a significant correlation with metabolic crisis. That was very interesting. There is no other phenotype that correlates with any other genotype um, listed here, but the metabolic crisis uh, stands out. And so to look more closely into the G154R variant, this is enriched in the ADMEX population, specifically self-reported Hispanic population. It is present almost in the middle of the protein. Um, and with the missense 3D mapping, you can see that it is the buried glycine that gets replaced, introducing a charge with the arginine present as well. And so the prediction of this variant, missense variant, is very damaging. Just through our collaboration with Dr. Claudia Gonzaga in Mexico, we've learned that this particular variant has been identified more commonly in the southeast region of Mexico. And so it has several carriers in the Mexican population and a higher number specifically in the southeast region of the country. And then the local ancestry shows that the variant resides within an indigenous ancestry haplotype. There is potential for population screening for this particular variant to identify any homozygous or compound heterozygous individuals that could be at risk for metabolic crisis. So, as I said, with the metabolic crisis in our cohort, we see this significant change or correlation with higher risk of metabolic crisis with this particular variant. This particular variant we also see has this G154R present, and it has been observed in the admix population, but the admix population is just trending towards a higher metabolic risk. It does not reach significance level here, and there is no other genotype phenotype correlation that I could identify. But this correlation, especially with the higher metabolic risk, is very essential especially for population screening in in the Tex-Mex region, uh, especially in the Rio Grande Valley, and that is something that Dr. Lalani is looking into with collaboration with Dr. Claudia Gonzalez. The slides are moving slower. Okay, so the next question that I wanted to ask here was, are there any clinical correlation that shape the disease course within the TANGO2 cohort? And so I have taken all the age variables within the survey data the data set that we have, and looked at Spearman correlation between all of these age variables. And so starting with that, we see that the early supplementation mitigates crisis as well as prevents any metabolic or cardiac crisis, as we all know, and this is just another way of looking at the same data. But one of the things that caught my eye was that the thyroid dysfunction frequently emerged following a metabolic crisis. And so if there is no crisis with early supplementation, there's a negative correlation with the thyroid problems. This is something that Dr. Lalani and Dr. Miyake want to look further into, specifically given the hypothyroid aspect that was also discussed today in the morning. Showing that they might be showing it earlier, but from the data that we have from the natural history study, I see that the thyroid dysfunction correlates with following a metabolic crisis. So if you're not having a metabolic crisis, those kids did not have thyroid dysfunction. And then the last thing that you note here is the age at start of the seizure. So age at which the seizures or spell or any delay happens, that is positively correlated to one another, trying to show that they all share the same developmental trajectory. And you all see this delay as well as the spells starting close to one another in the developmental age range. So far I've shown you how the G154R variant is linked to metabolic crisis and how early supplementation and the correlation that we've seen with the first crisis as well as the thyroid dysfunction. The last question that I wanted to emphasize more on um, is trying to look at the different clinical subgroups, that if I can identify any clinical subgroups within the TDD cohort. And to do so, I move to something called as human phenotype ontology terms. So I'm converting every phenotype that any clinician lists into a code, which is called the human phenotype ontology code, or HPO codes. So this is a known hierarchical standardized ontology. It has over 15,000 biological standardized terms within them. And this hierarchical structure is in a way where you have general terms on the top. And as you go down the tree, the specificity of the term increases. And so every term gets this unique code, which is HP, and then the seven numbers. And so now this is human readable as well as computer readable, and so supports computation. One of the things to note is when you have the specificity of the terms, and if you are specifying, for example, if you specify the arrhythmias that may be present, or specify any particular phenotype that may be like joint hypermobility, rather than abnormality or spasticity and things that are more general terms, the information content of that increases. And so I will explain how that information content is very necessary in the things that I do later on. So now these terms can be used to compare cases from one case to another and group cases if they are similar or different and see their trajectories as well. So this can be a you can have phenotypes that are taken longitudinally as well. So you can have it from the first interview as well as from those phenotypes that are from the follow-up interview. Once you have all of these HPO codes for every case, you can now use lin semantic similarity to generate this matrix between these cases and see which cases are more similar to each other than not. On this matrix, then you perform unsupervised phenotypic clustering, and that generates this heat map with a similarity score that is coming from the lin semantic similarity. I am waiting for the slide to change. Okay. So as I said, you can observe the whole matrix in a heat map, like you can see on the left. Here I have all the 120 individuals on every row and column of this heat map. So every column and every row has the individual. When an individual is compared to itself, it will have the highest phenotypic similarity score of 1, shown in red. So you see the diagonal running through. And now you can see clusters of cases that have higher similarity scores closer towards the red side. So using gap statistic modeling to identify the number of clusters, I see that you can clearly denote 3 clusters here, and those have been labeled by green, red, and blue on the top. What does these 3 clusters mean, and what are the phenotypes that are driving these clusters? So looking at the significant terms that are present, or HPO terms that are present in each of these clusters, I see that one of the cluster 1, does have all the major major phenotypes that you would note in TANGO2 cases and are affected but do not have any cardiac crisis here. And nor very few have had metabolic crisis as well. So their EEGs and metabolic crisis are lower, but they still show speech and language development delay, developmental delay, intellectual disability, and the muscle weakness, and then the myopathic abnormalities, as you would expect. But in cluster 2, you see that these are cases that have the metabolic acidosis, they have the cardiac arrest. So these are very severe cases. And then you have the third kind of clinical subgroup, which is in between. So they may have had cardiac arrest and metabolic acidosis, but do not show this muscle weakness or myopathic abnormalities and gait and ataxia as you would see in cluster 1 and 2. I've shown the number of clusters or the number of cases per cluster down here, which is almost similar. Only the cluster 3, there are very few of them, almost half. And then the age of range of which they were on multivitamin, and that is almost similar. Yes, cluster 2 is a little bit higher, and you would expect that since they were severe, so they probably started their vitamins a little later as well. So we see that when you see these 3 groups, I kind of put them as moderate, severe, and mild. And now, once you have these follow-up interviews, you can even add the follow-up phenotype terms and get a longitudinal aspect of seeing if cases do move from cluster to cluster or do they stay in the same cluster as well. And if they stay in the same cluster, what if we do see that longitudinally, what is the management strategies or treatments that they have been getting, as well as what are the um, the environmental factors that have been playing a role in their disease progression. So these are things that we can take from here. So with that, I wanted to give you this whole overview of what I have been doing from the or learning from the natural history study data, very specifically looking at the G154R variant that shows to have a high link to metabolic crisis. Um, again, showing how early supplementation mitigates crisis, and then finally, with using HPO terms and the unsupervised phenotypic clustering, showing the three distinct phenotypic subgroups within the TANGO2 cohort, and so how we can see them longitudinally as well. And with that, I would thank the Baylor TANGO2 Natural History Study team, specifically Dr. Lalani and Dr. Miyake for their mentorship, and I'm happy to take any questions.
Thank you, Nikita. That's very interesting information. While I'm waiting for some other questions to come in, I can ask a couple of ones that kind of came up while I was thinking about it. One is, do you have any data on the use of B vitamins at an earlier standpoint with the G154R as an explanation for kind of the increased metabolic decompensations in that patient cluster?
So, yes and no. Most of those had metabolic crisis. We have 8 cases, and all 8 cases have had metabolic crisis at an earlier age, I believe at around 1.5 years. And so the supplementation was only started after their metabolic crisis. One of the things that Dr. Lalani really wants to do because of that is the population screening, so that we can catch them early and start multivitamins even before they go into a metabolic crisis. So that is a project that she's really looking forward to doing, like a population screen for that particular variant.
Because it would be interesting to know if like there is a time lag between the earlier section of population that is the G154R patients that didn't necessarily have the B vitamin knowledge in place in terms of their initial presentation with metabolic crises as an explanation for the earlier crisis. Just given the other information we know about kind of the homogeneity, like the general same sort of pathway with loss of function variants.
Yes. So we are not sure of how specific this variant is in disease progression or like changing the disease as much, specifically looking at loss of function variants or exonic deletions, things like that. Because even within these 8 cases, these are not homozygous. These are 4 of them are compound heterozygous with exonic deletions on the other allele. And so it's not specific for, it's just that we have seen that whenever you have even one copy of this G154R, these cases have gone into a metabolic crisis. There could be socioeconomic status, misdiagnosis, all of these factors that may play a bigger role in showing us this data, or like pushing this data into significance level. And that is exactly why having a population screen or an earlier identification might help, to see if it's just this or is there something specific with the variant as well.
And I guess Mike asked the question, do you anticipate some of the phenotypic differences between cluster 1, 2, and 3 to converge over time with B vitamin intervention? And I wonder if some of that is also true in terms of like is the more mild cluster 3 disease in family members that have a known diagnosis, or is it skewed to cluster 1 and 2 as like probands?
No, I looked into that. That is a very good question. The cluster 3, the mild group, also has a few probands. Very interestingly, if you look at them, they also, the cluster 2, which is the moderate group, and then the mild group, have started slightly early the B vitamin supplementation, but I was hoping I would see like cases with B vitamins and not B vitamins. If I go only at the first interview phenotypes, that's something that we wanted to look at as well, versus a follow-up. And then this is a merged heat map that I showed you. They do not converge. So there are still cases who have had B vitamins, but show a different trajectory with their phenotype differences compared to some of the cases that are still severe. They don't go into metabolic crisis, but still have very severe, like muscle weakness, ataxia, things like that, gait abnormalities that you still that still linger on, even if they're on B vitamins. And that's something that we want to kind of longitudinally see. And this is a good way of seeing that differences between cases.
Very interesting, and continues to highlight the importance of like participation and having like the good follow-up studies.
Yes, yes, definitely.